toxin critical and then do temperature. For calcium channel blockers, and really, I think Dr. Fowler has set it up the way I used to set up this course. You do all your vasoactives first, like a kind of as a unit. So you already have peripheral vasodilators or antihypertensives, diuretics. Have you had peripheral vasodilators? Like nitroglycerin.
In nipride, yeah.
Oh, yeah, that's peripheral vasodilator. Alpha beta antagonists, not yet, right?
We've had that as well.
You had that as well?
Yes.
Wow. So this is the last of those lectures.
Yes.
Am I missing something? All right. I think it's very important that you, as you learn all these drugs, there's so many of them, and you all come from different backgrounds. Some of you use most of these drugs a lot, and some of you some. You know, that you really understand the differences, why the differences, the general overall impact of the kind of drug. Like, you know, when you're all of a sudden in clinical and you're like, okay, my patient clearly has a problem with an elevated systemic vascular resistance. What kinds of drugs am I going to look at to help me in this situation? Then you start thinking about, well, what kind of drugs are longer acting, shorter acting, contraindications, et cetera, et cetera. But you're going to think in terms of why is the blood pressure high? Why, you know, and then trying to pick a drug that helps solve the reason. For an example, just jumping ahead, your patient has an elevated ICP. And Cushing's triad says that when you have an elevated ICP, you're going to have what three factors?
Bradycardia.
Bradycardia.
Widening
pulse pressure, meaning the diastolic drops or the systolic?
Systolic. Raises the diastolic drops.
Yeah. Well, it's more that you get hypertension. So just think of it, like we talk about that pulse pressure, but really what you have is hypertension. You know, they just get really hypertensive. And the third one, you'll not even hardly deal with, that, yes, but not part of Cushing's triad.
Okay.
The other one you'll hardly ever deal with in anesthesia world.
Yeah.
Yeah, you're on the right track. Irregular respirations. It's irregular, and you won't hardly ever deal with that because.
Is that what it is?
Exactly.
Those big,
so, because you're going to be ventilating the patient, so you won't notice. Although if you get a patient not intubated, you could see it, and I have seen it. I'm like, wow, this patient's showing all the signs. So all of a sudden you have Cushing's triad, and you have this hypertension, and you're like, okay, I need to treat this. What am I going to do? Well, why are they hypertensive? Is it because they have a hyperdynamic heart that's beating like crazy? Or is it because systemic vascular resistance is high? Yes. And so then that's the path you're going to go down. You're not just going to think in terms of, well, I have a high blood pressure and a low pulse, so I need to do, I mean, you do need to think that, but you also need to think about what is going on and why is this occurring? Let's say someone has essential hypertension. They're just hypertensive. Like most people, they have essential hypertension. Well, is that a problem with systemic vascular resistance? Yeah, pretty much. Essential hypertension, the problem with the vasculature, right? So, are you going to be giving a beta blocker to treat essential hypertension?
No.
No. Now, you might give esmolol as a little stopgap or something like that. I'm not saying you'll never do that, but you need to be thinking about why are they having what they're having. You know, so what if they're having a massive sympathetic response? Let's say they're jacked up on coke, right? And they're just having this massive systemic sympathetic sympathomimesis. Are you going to focus on a peripheral vasodilator only? Are you going to focus just on SVR in other words? Are you only going to focus on ionotropy and the function of the heart? Or are you going to focus on the entire picture of systemic vascular resistance? Of sympathetic nervous system, sympathomimesis. I'll give you an example with that. You have a patient who is jacked up on coke, and their heart rate's 120, their blood pressure is 190 over 110, And if you only treat one thing, let's say you only give them a beta blocker, are you going to help the heart rate? Yes. So you basically reduce the heart rate. What did you do to contractility? Improved it or reduced it? You definitely reduced it. Beta blockers are negative inotropes, right? Yes. And what did you do to systemic vascular resistance? Nothing. So basically you said, okay, heart, you can work less hard against a lot of resistance. That's a great way to treat your patient. See what I mean? So at the same time, though, if you only give a systemic vascular resistance dilator, something to reduce that, now you've got a super hyperdynamic heart against soft vessels. That's not a good balance either. Those are the kind of things you need to do. So it's not just about heart rate and blood pressure. You'll see what I mean when you get in clinical live, and you'll easily fall in that trap. Well, what do I give when my blood pressure is high and my heart rate's low? That's part of what you need to think about. Okay. All right. So today we're going to focus on calcium channel blockers, although I'll probably delve into all the drugs a little bit, just because I want you to see the big picture. One of the things I want to really a take-home message. Calcium is the mother of all contraction. In the body, contraction is totally tied to calcium. Whether you're talking about ventricular myocytes or vascular smooth muscle. The end result of an increase in intracellular free calcium is contraction. So when you're trying to treat vascular smooth muscle resistance by dilating the vascular smooth muscle, what you're trying to end up doing in the end is decreasing the amount of calcium that's free in the cell. Okay. That's it. There's so many ways you go there to get it, but it all comes to calcium. If you're talking about ventricular myocytes, same thing. You're trying to decrease that calcium. And by doing that, you have less squeeze of the heart. All right, so we're going to talk about calcium in cardiac and smooth muscles. We're going to talk about that change of intracellular calcium, and the excitation and contraction coupling is the process in which calcium channels are activated and exert their effects. So when it comes to cardiac muscle, what is that protein that is unique to cardiac muscle as opposed to vascular smooth muscle? Troponin, okay? Otherwise, you have actin, myosin, all that stuff, both. But you have troponin as well in the cardiac muscle. And calcium binds to that troponin C and releases troponin I inhibition of the actin-myosin interactions. But in smooth muscle, calcium binds to comodulin. So you need to remember, what does calcium bind to in each of the two types of cells? Okay? And that binding the comodulin that causes that actin-myosin interaction. Both are regulated by G protein, adenylate cyclase activation, and cyclic adenosine monophosphate, IP3 activity. Okay? So, we have a, what kind of cell are we looking at here? Myocyte, because I have it on my thing. What is your other clue that this is a myocyte?
Sarcoplasm.
Troponin! Boom, right there, right? So, and actually I saw that first when I decided to ask the question. I didn't even look at the title. Okay, so troponin. So, you can see that all these different things involved is all about calcium. All about increasing free calcium. Whether you're going to work on the channels and allowing calcium to come in, whether you're going to work on allowing calcium to be released from the sarcoplasmic reticulum, however you're going to do it, that's the goal for an increase in contractility. All right, and this picture comes from an old physiology book that I thought was a really cool thing. It just kind of shows that process, and you can read this to get it. But the bottom line is, calcium comes in, binds to troponin, and it allows that ATP. And I think it's cool that they show it as a battery. That's a battery, like a 9-volt battery. We still use those sometimes. But anyways, ATP, and then when it loses its phosphate group, it becomes ADP, that's that suspension of energy, and that allows that fiber to come and pull together. This is vascular smooth muscle. So think of this as the smooth muscle wall. And whether you're talking about different G proteins, and this I got from cbphysiology.com, by the way, excellent website. cbphysiology.com, cbpharmacology.com, when it comes to cardiovascular stuff, when it comes to action potentials and all that stuff, great stuff. So I encourage you, especially if I tell you anything that you're like, what? Go read. And it's not like exhaustive either. I mean, you can they drop it down into little pieces. And another nice thing is a lot of the words are hyperlinked. So like when you see comodulin or something, there'll be a hyperlink and you can click on it, it takes you to comodulin. Excellently put together website. But anyways, and if anybody really likes electrophysiology, like that's just kind of your thing, they actually have a textbook too. It's not that expensive. I bought it, years ago. I read it. Think about rereading it because it's really fascinating stuff to me. I tell you, when I was going to think about my doctorate, the doctorate I wanted to get was a PhD in electrophysiology because this stuff fascinates me. But then I realized I'd have to quit work because the PhD in like a hard science like that, you have to become faculty, like work with a faculty member and full time and teach and all that stuff, and you get paid nothing. And I was like, yeah, no. GP sounds great. So I'll just have to do this stuff on the side, kind of like learn about wine or whatever, something. Okay, anyways, woo! All right. Exactly. I don't actually, yeah. Thanks for reminding me of my nerd card. Okay, so all right. So anyways, you see here you got your different G protein receptors, and each of these have to do with different, and if you go there, it'll tell you which ones are norepinephrine, which ones are epinephrine. But in the end, they're all leading to either an effective amount of cyclic ABP, like increasing it, or the IP3 to affect the sarcoplasmic reticulum. Calcium. Nitric oxide affects the cGMP, which then leads to a change in the myosin light chain phosphatase, I think it is. This is myosin light chain kinase. All of them affecting, in the end, either calcium or calcium's binding to comodulin. Over here, how about just a plain old calcium channel? Today's topic. If we open up that channel, what's going to happen to calcium? It's going to go into the cell. What's that going to do to contraction? More contraction. Hence a calcium channel blocker. Exactly. All right. So all these things, in the end, calcium and calcium's role are where all of our drugs work. Okay. So regulation of intracellular calcium concentration. So first of all, normally at rest, whether you're talking about vascular smooth muscle or ventricular myocytes, at rest, the concentration of calcium in the cytosol is very low. Where is all the calcium in the cell? So calcium bound to the cytoplasmic reticulum is basically inert. Okay, it's not doing anything. Right? But then you get that calcium release, and that's when it does what it does. So you're either going to try to get more calcium release from within the cell, or get more calcium into the cell, or affect that calcium's ability to bind to things like actin-myosin. Via binding comodulin to affect actin-myosin. So, and once that contraction is terminated, ion pumps return the calcium to the sarcoplasmic reticulum vesicles. There are 6 types of calcium channels. I told you my Mu story, right? Yeah, I know I did. Where first day of class, Dr. McDonough's lecturing, and he said, "Where does morphine work?" And I thought I was really good to say opioid receptor. I was like, wow. And he said, "Which one?" And I'm like, ah. And somebody goes, "Mu." And I said, "Mu? What does cows have to do with this?" We've heard of mu. And then he starts saying, "What are they?" And he does that. Does he still do that? Once you answer a question, he asks you another one until you can't answer. Well, name the other kinds of receptors. And if you can, then, well, tell me the difference between mu1 and mu2. You know, and you don't go until you don't got it, you know, but that's fine. So anyways, yeah, there's always another level. There's always another level. So when we get to the hypothermia lecture later, I was just reading another article yesterday where now the same guy is named Sessler, who is kind of the guru of hypothermia in the anesthesia world. He's now identifying like very specific subtypes of receptors in the brain, like things that have letters and numbers and stuff that I had no time to really read about when it comes to regulation. And I'm like, wow, that's the next level. I thought I was already there. No, I'm not. So anyways, there's always another level. So we're going to talk mostly about L-type and T-type channels. Calcium channel blockers mostly work on L-type channels. There are 5 subunits of calcium channels, L-type calcium channels. Guess which ones we focus on? Alpha. Isn't that wonderful? All right. How do they work? Well, first, let's talk about the classifications. And some of these names you'll never heard of before. The first is the phenylalphamines. There's only one, and that's verapamil. This is an old school calcium channel blocker. The next one is the benzothiazepines. And I always joke because I used to make the students know that word. And one time I was in clinical and I said, what is diltiazem? And the student said benzothiazepine. Someone else was standing right next to me and said, are you kidding me? You think diltiazem works on GABA receptors? I said, no, they did not say benzodiazepine. They said benzothiazepine. There's a difference. They know what they're talking about. So anyways, but nobody knows that. Benzothiazepine, but it is actually the classification diltiazem comes from. And then the 1,4-dihydropyridines, also known as DHPs. So on a much more functional, useful, and well understood level, you really need to categorize your calcium channel blockers either dihydropyridines or non-dihydropyridines. Meaning verapamil and diltiazem are non-dihydropyridines, and then everything else are dihydropyridines. And it is so good to think of it functionally that way because the non-dihydropyridines, when it comes to the heart, and especially the heart rate, they behave absolutely opposite to the dihydropyridines. Because all calcium channel blockers cause vascular muscle relaxation. They'll all lower blood pressure. But some slow heart rate, and some indirectly raise heart rate. So the dihydropyridines are specific to vascular smooth muscle. So here's a chart that shows kind of which ones have the most effect. I don't really think it's necessary for you to, I don't want to speak for Dr. Fowler, but that's where you know that which ones are slight, which ones are a little more than slight or whatever. It's more like look at the extremes and look at the trends. So we have here, the top two are our 9-dihydropyridines, and let's look at the SA node. No effect on the SA node when you get into these two, or any dihydropyridine. No effect on the AB node. As opposed to the non-dihydropyridines, where there is some effect on these two. But then when you look at things like coronary vasodilation, they all do it. Which one does it the most? Dicardipine. Suppression of cardiac contractility. Difedipine arguably has some moderate, but really, in general, dihydropyridines do not suppress cardiac contractility, but the non-dihydropyridines do. There are actually 5 major classes of calcium channel blockers, but 2 of those classes, we no longer have those drugs. These are the last 2. So those, if you have the last year's slides, I finally got around to knocking them out of the slides. I used to always think, just you don't need those. Now they're gone, except for that they're here, but yeah. The actual slides on those drugs are gone. So, non-dihydropyridines. Negative inotropes, meaning what? Decrease in contractility, which is about how the heart squeezes, like the intensity of that squeeze, right? It's not about volume, not about stretch, anything like that. It's about how hard that myocyte squeezes. So what do you think is the key factor to contractility? Calcium, right? If you look at any inotropic drug, by whatever method they do, they increase calcium. Does anybody, this is an aside. Okay, first, maybe some positive inotropes for me.
Epinephrine.
Dobutamine,
Epinephrine.
milrinone, that's the one I wanted to ask about. Isoprel. What is isoprel? What is it?
Beta.
Good. Dobutamine.
Dopamine.
What is dobutamine?
Beta.
Yeah.
Is it a beta agonist,
beta.
alpha
Beta
agonist?
1 agonist.
It's beta.
All beta.
It's beta.
All beta.
Yeah.
What else?
Do we say epinephrine?
Epinephrine?
Yeah.
What is it?
Everything.
Everything.
Yep.
What's the other one that's everything?
Norepinephrine.
Norepinephrine. Which one has a little bit more alpha than the other?
Norepinephrine.
Norepinephrine. Y'all need to know this stuff.
Yeah.
What else?
Ephedrine.
What?
Ephedrine.
Ephedrine, what is that?
It's alpha 1 and also beta 1.
Indirect.
Yeah. What is also unique to ephedrine?
It's direct and indirect, but I'm not quite sure.
And exactly, but the fact that there is some indirect property, most of the sympathomimetics we do, they're all direct. So ephedrine has that, and you're right, it is direct and indirect. And so if somebody's catecholamine depleted, that's where ephedrine is not going to be very helpful for you. What else? Anybody say dopamine?
Yeah.
Mm-hmm.
You did?
You did.
Okay, what is it?
It does both, right?
Dopamine and
What, both beta and alpha?
No.
D1.
the D1 through 5.
Inotrope and also vaso.
Well, a lot of the drugs we mentioned are inotropes and vasoconstrictors. The exceptions are, which ones so far are, that are mentioned so far, are inotropic but not vasoconstrictors?
Milrinone.
That's one.
Iso.
Isoprel.
And then dobutamine, probably.
Dobutamine.
Yeah.
Right. Dopamine has alpha effects, so therefore it actually does vasoconstrict. But if you have a beta agonist only, there's no vasoconstriction there.
Yeah.
As a matter of fact, beta 2 agonism actually can cause some mild vasodilation. There's others. What's milrinone's classification?
Phosphodiesterase inhibitor.
Phosphodiesterase inhibitor.
Yep.
That's right. And in the end, milrinone decreases intracellular calcium. But in the vascular smooth muscle, it does it differently depending on whether or not you're telling myocyte or not.
Yeah.
But in the end, that decrease in intracellular calcium in the vascular smooth muscle is why milrinone is actually a vasodilator, not a vasoconstrictor. Yeah, so if you have somebody who has high afterload, but not so good contractility, milrinone is excellent.
Maybe also be good for, I don't think it's nifedipine, but maybe also for milrinone cerebral vasospasm.
Okay.
Oh, that's
I
interesting.
didn't know that, but
Yeah.
okay. It's also, arguably a little bit helpful for pulmonary hypertension, but
Well, that's the word. That's what we use it for.
I don't know. I've used a lot of milrinone, and I don't know that I really saw it be a wonder drug for that. But yeah. It's used for that. So, okay, anyways,
That
all the stuff,
Viagra.
if you feel overwhelmed with what I just said, that's okay, but learn it. Okay. All right, so negative inotrope is specifically the contraction. Negative chronotrope, decrease in rate.
Mm-hmm.
Negative dronotrope, I'm going to get to the difference between the two. Positive lusotropic effect, what is that?
Relaxation?
Yeah, relaxation of what?
The myocardium.
The myocardium. So it just relaxes that myocardium. Okay. All right. I love this stuff. Okay, so let's spend a little time on this. I know I drew this for you last semester, and talked about it to some degree. So we have this, we have this, and we have probably one of the only things I draw pretty well. Actually, that's not very good. Let's try to make it about the same slope. Okay. These are the three action potentials in our bodies primarily. This one is the most common. All our muscle, all our neurons, everything, it's just sodium in, chloride in, repolarization, etc. Ventricular myocyte, right?
Mm-hmm.
Talk about that a little bit today, but we're really going to talk about this guy right here. This is the one that nobody knows about, because there's a lot of physicians, I think, that don't. What the heck is that thing? This is how our SAM works. This is wonderful because we don't have to think to make our heart beat. The physiology, the gradients, the movement of electricity is the reason why our heart beats, and it does it on its own, just on its own. And so we have, what's this phase?
4.
4, 0, 3, right? And oh, it's still there. Okay, good. And then back to 4. All right. So and on. So what's going on here? So keep in mind, we're talking about this axis is voltage, right? So the farther down we are, the more negative we are becoming, right? With all of these, that's the case. Which means, when it comes to ions, where are the positive ions more located? Outside or inside the cell? Outside the cell, as opposed to inside the cell. There's some kind of gradient of positive or negative ions creating this negative voltage, which is what we call that potential, right? That resting membrane potential. And so for this to be climbing, that means the voltage is becoming less negative. That's happening because either positives are going in or negatives are coming out, right? And so what positives would go in, and this is all about channels, okay? This is not pumps, this is channels. What channels would allow positives in?
Sodium.
Sodium, calcium,
And chloride.
What about potassium?
Gotcha.
Potassium doesn't go in via channels, right? So it can't be potassium. Any other positives? I mean, you could
H
argue
positive.
magnesium, but not really, okay? So it's really sodium and calcium, all right? When you see the slope coming down, what positives could be going in that might help cause that?
To make it more negative?
None, okay? What negatives could be going in?
Chloride.
Chloride. What positives could be going out to help?
Potassium.
Potassium. Okay. So now, if you were ever in an ACLS class, or maybe in your undergrad class, or you were in any kind of class that talks about whether it be the one that most people are familiar with, or this one, or anything, there gets to be all this confusion about what's going in and what's going out, and that's partially because you see stuff like this. ICA, K plus, you'll see these terms, and you might even see like this. Because this threw me off at first too. I saw something like this. G, that's a G, K plus, like that. And this is where everybody gets confused, because they see this up and they think that means in. Does anybody know what G stands for?
Gauge.
G-coupled protein?
Not in this case. Conductance.
Mm.
What does I
No
stand
idea.
for?
Impedance?
Current.
Oh.
Good guess. Current. Okay. So conductance just simply means it's moving. It's conducting from one place to another. So if there's an increase in the conductance of potassium, meaning potassium is moving more, where's potassium going? Out. It always goes out via channels. This is all about channels, okay? So this is where people get confused. They see something like this and they go, okay, I know in my study guide when I was in undergrad, it said that potassium was going in there. That's because somebody used that term or whatever you looked up, it used that, and you didn't understand that it just meant conductance. So same thing here, when it's showing this here, they're using the term current. Current is now just an electrical pathway movement, which is caused from conductance. So that means that these channels are actually functioning during this time, or open during this time. Okay? IF is the funny sodium currents. They're called funny currents. Didn't know that, did you? I didn't either. But anyways, so they're the funny currents. So if there's a current going on, that means if it's a sodium current, that means sodium is going where? Into the cell. So would these currents explain a positive upslope of the graph?
Yeah.
All three of them?
No. The initial was sodium and then followed by calcium.
Sodium and calcium are the two we're talking about. Would an increase in the conductance or current of those three channels explain a positive upslope of the graph?
Yes.
Yes, it's all positives and they're all going in, right? And you see here, finally that's open here. If the potassium channels open more during this phase, would that explain a downslope in this?
Yeah.
Yes.
The negatives are coming in.
See, when you understand the terminology and you understand what's going on, it makes sense. All right? So what is happening in general? During phase 4, sodium is leaking into the cell. We're talking about the essay note here. Sodium is leaking in, then calcium starts to leak in, and it leaks in and it becomes less and less and less negative, and then it reaches threshold depolarization, which is much faster, the slope is much higher. This is phase 0, where calcium really opens up and starts really coming into the cell. And then you have potassium, and there's other things involved. There's some chloride going on here. What you don't have is that threshold or that plateau phase, which is like from another kind of calcium channel, which is involved with the ventricular myocytes, okay? But that's what's happening here. So if we want to affect heart rate, and every drug that does, that's true, that I can think of right now, it all has to do with this. It all has to do with this. So how could we lengthen this out? What are some of the things we could do? What can we do to this slope to make the heart rate slower? We can drop the slope down, right? Because if the slope drops down, it will take much longer to reach that threshold point and have your depolarization. What else could we do? We could have this come much farther down. We could hyperpolarize the cell and have you go to a lower resting membrane potential, meaning it's going to take longer to get there as well. Well, I don't know what button I hit to change that much. All right, so back to the question. Chronotropic versus dromotropic. What is the difference? If something is negative chronotrope, that just basically means the heart rate decreases. Why? Well, in the case of calcium channel blockers, it's because it has a negative dromotropic effect, which basically means the conduction velocity is decreased. We have less conduction speed, and so in effect, you're going to have less pacemaker cells firing as often, and you have negative chronotropic. So calcium channel blockers of the, which classification are we talking about right now? Non-dihydropyridines have a negative chronotropic effect because they have a negative chronotropic effect. So this one really shows, and this is all from CV physiology and CV pharmacology. Good stuff. Anyways, this one shows that same effect. So in the sympathetic description here, you can see that this slope is more sharply, it's coming up more sharply, meaning you reach threshold more often, and the heart rate is faster as opposed to normal. Okay. When it comes to the vagal or the vagal explanation, if you have a parasympathomimosis, what you do is you open up potassium channels more, and that allows you to come down into a hyperpolarized state, and that makes it slower. So this is the coolest thing. When you're talking about the sympathetic nervous system, you're all talking about these calcium channels that are on this side of the action potential, causing it to happen faster. When you're talking about the parasympathetic nervous system, the focus is on the potassium channel, causing it to come down further. Now it takes longer to get back up. Okay, I think it's cool. Anyways, all right. I also love this slide because it explains what we already understand. When we think about EKG interpretation, you talk about why QRS. Check this out. What do we know is fast? What are the fast areas of the heart, like when it comes to conduction of electrical current?
Atria.
The what? The Purkinje fibers are fast. What else are fast?
Atria.
The bundle of His is the big focus, right? What's not fast? What's like really slow? AV node and cell-to-cell conduction.
Yeah, ventricular fiber.
Right? Hence your QRS duration for a bundle branch block. Because what's happening with a bundle branch block is everything's flying down except one area, and that one area, now you have to have other cells that are depolarized send that signal from cell to cell to cell to cell to cell to cell until finally that other area gets conducted, and all that's that QRS that you see. But this shows it in meters per second, the different parts of the heart and how fast they are. Look at Purkinje fibers, 4 meters a second in comparison to the AV node, 0.05 meters per second. Huge difference. But let's just to compare apples to apples, because AV node and Purkinje fibers don't really have anything to do with each other. The bundle of His at 2 meters per second, the cell to cell, 0.5 meters per second. So the bundle is 4 times as fast. Yeah.
I was going to clarify the SA node has a faster intrinsic rate though, right? As it gets...
Well, the SA node just sends that signal. I don't have the number on that.
Okay.
But the SA node is where the signals originate. From anybody know what kind of cells? What they're called?
Pacemaker cells?
Yeah, but what do we mostly call them? It's actually probably the best answer, come to think of it. P cells. They're called P cells. Anybody ever heard that? But probably the reason why they are is because they're called pacemaker cells. But anyway, that's this signal over here, and it sends it down via atrial muscle at 0.5 meters per second.
Interesting.
And then it hits that AV node and it slows everything down. And then it's on the highway. We're on the Autobahn now. Or in Montana. Anybody ever driven in the highways in Montana? Did you ever get a ticket for going too fast? Apparently they can give you a ticket for going too fast, but it's not for speeding, it's for reckless driving. I don't want to speed, but it's some of the highways. Anyways, sorry for the asides. Anyways, all right. Not really. Pharmacology. All calcium channel blockers, all of them, decrease coronary vascular resistance and increase coronary blood flow. They decrease peripheral resistance via vasodilation arterioles and are without significant effect on venous tone. So they're primarily arterial dilators. Okay. What's one of our drugs that is mostly venous? Nitroglycerin.
Mm-hmm.
Yeah. I don't know. Did you say nitro? Is that what you said?
I did say that, but
Okay. I would ask for clarification. I just thought maybe you said something else. I wasn't sure. Yeah, nitroglycerin. Although, does nitroglycerin have arterial effects?
at certain doses. On higher doses.
It can, yeah. Why does nitroglycerin help with angina? How does it work?
Preload.
Preload. I hear preload.
Well, we're
Nobody
always,
wants to jump on coronary vasodilator?
well, that's the word. That's what we're always told.
And that's an artery, right? Those are arteries.
It decreases
I think it decreases preload.
preload.
How does decreasing preload help with the
Yeah. Well, because you're perfusing the coronary arteries during diastole, and so decreasing preload would decrease cardiac output, like more or less, via Starling.
Does nitroglycerin dilate coronary arteries?
I don't know. That's what I was
Is
told.
there any effect on the coronary arteries from nitroglycerin?
Yes.
It absolutely does.
Yeah.
Is that why it helps with angina pectoris? Not really. That's not the main reason. And when you talk about preload and all this stuff, that you're dancing all around the reason, okay? First of all, you got to get off this idea that perfusion of the heart, when it comes to like MIs and angina like that, has everything to do with coronary arteries. That's only part of the picture,
Myocardial work.
right? Because it's not like your main coronary arteries go get to every cell in that heart. They're the main pathways that then get into the coronary capillaries, which perfuse all of the endocardium, right? And so you know, because this one was a hard one for me, because I was like, okay, so because when we talk about the preload, we're talking about if you have high preload, the heart's stretched out. And I'm going, yeah, but I've seen those coronary arteries. They're on the outside of that heart. So what? How does that really like squeeze on those coronary arteries? Not that much, actually. But what do you think that does to the endocardial, like the small vessels in the endocardium? If that muscle stretched out, that endocardium is stressed, and so now you're increasing that venous pressure against the coronary perfusion pressure, because coronary perfusion pressure is what minus what?
And maybe you can measure it and see something.
What's coronary perfusion pressure? I've asked you this one before. What's coronary perfusion pressure? I'm sorry, cerebral. Did I just say that?
Yeah.
There you go. I thought I did. Cerebral perfusion pressure. I know y'all nailed this one before. Math minus ICP, right?
Yeah.
Okay. What is the general perfusion pressure of almost any organ in the body?
Minus the
Pressure, whether it's
The capillary
Which the best way
pressure.
we can measure that is really the MAP minus the venous pressure of that place, which we don't usually measure. So our general idea is, what's the pressure we measure to give us the best idea about venous?
CVP.
Right? So no, but the best answer is yes. If you're talking about the pressure, the perfusion pressure of the kidney, it would be MAP minus the venous pressure at that kidney. That is the best answer. But we don't measure that pressure, right? So what about coronary perfusion pressure then?
So-
would be minus CVP.
No. Neither one of those are actually.
Diastolic pressure
What? Diastolic
Yeah.
blood pressure
minus the
minus.
the
Right atrial and diastolic.
ventricular and
What do you hear it?
diastolic.
Left ventricular end diastolic pressure, which is the venous pressure, really, on the main part of the heart. The left side is what we focus on the most, right? And now, does the systolic blood pressure have anything to do with coronary perfusion? Absolutely it does.
If you're
But
afterload.
the diastolic blood pressure is the biggest piece of that puzzle. So that's why it's diastolic minus left ventricular and diastolic pressure. That was an aside, but I think it's important. But anyways, back to the nitroglycerin. So if you can decrease that venous pressure, meaning your like LVEDP is low, right? If you can decrease it, you're helping what passive filling through those cells, because it is passive in the heart, get through. That is the main reason why nitroglycerin works for angina pectoris. As opposed to, like, let's say nicardipine, which it won't do anything for the LVEDP at all. It will dilate the coronary arteries, so it can be helpful, but it is not the drug of choice for angina pectoris like nitroglycerin. The other problem with nicardipine is you're also going to decrease diastolic like blood pressure by giving nicardipine. So yeah, you might dilate the coronary arteries, but you're also going to drop the blood pressure. Is that really what you need to do? You know, in the case of, if the problem with it is coronary perfusion, not because their blood pressure is so high that the heart's working so hard against it, then the best choice is nitroprusside for that. So, all right. Indication for calcium channel blockers: variant angina, exertional angina, unstable angina, arrhythmias, but not dihydropyridines, right? You're not going to give dihydropyridines for arrhythmias. So they aren't going to do anything for arrhythmia, okay? Non-dihydropyridines are great for controlling PSVTs. If you've ever heard that verapamil and diltiazem are absolutely contraindicated with Parkinson's white, that comes from like the 70s and 80s. I think there's an article published like in the 80s that said that it will kill your patient. They've actually now kind of retracted that. They said it's not drug of choice. It's not preferable. You need to be cautious, but it's not what we thought at first. The whole idea was if you gave them a calcium channel blocker or a beta blocker for that matter, you're going to just suppress the AV node and you're going to encourage the alternate pathway, leading to like a one-to-one conduction. That was the whole theory, but they found that that's not totally true. But you do, you know, it's not the choice. Indications: hypertension, thoracoid hemorrhage, hypertrophic cardiomyopathy. Side effects: orthostatic hypotension for sure, bradycardia for non-dihydropyridines, tachycardia for dihydropyridines. Peripheral edema, dizziness, headaches, flushing. Not vomiting is a side effect for every drug in existence. Water probably isn't causing vomiting. Anyways, okay. So it can potentially aggravate myocardial ischemia by this theory of coronary steal. It's very controversial. Verapamil can increase your digoxin levels. AV blocks can convert. You can read. Okay. So let's talk a little bit about that dihydropyridine. I know it says weak SA node navy junction effect. That has caused some confusion on tests before. I'm telling you right now, just treat it like it has 0. Okay? Little or none or 0. Like, it doesn't affect the SA node navy node. So, if you give someone nicardipine, what's going to happen to their heart rate?
Same. Stay the same.
What should not happen to the heart rate? It should not drop, right? And I'm going to tell you it actually increases. The reason is because of the baroreceptor reflex, right? Because if you have hypertension, and this is actually why in Cushing's triad you get the bradycardia. One of the main reasons is because that hypertension leads to the bradycardia at the chemoreceptors at the carotid sinus and elsewhere, okay, aortic arch and all. So the chemoreceptors are responding to that high pressure. And by responding to that high pressure, what happens there? What does the baroreceptors do?
I just want to clarify.
Yeah.
Baroreceptors or chemoreceptors?
Baroreceptors, thank you.
Okay.
Baroreceptors. What happens at the baroreceptor? What do they do?
So they sense the change in the diameter of the vessel, and they send a signal goes to the medulla. A signal goes to the a signal goes to the medulla.
Somebody want to pick another destination of the signal? Not medulla.
The brain.
Because is it a reflex? Because it doesn't have to go to the brain if it's a reflex.
Where does it go? What are we talking about here? Heart rate. Where does it go? The SA node.
It goes directly to the, because I thought the mechanism was to go to the medulla and then releases,
Does it take like the vagus nerve?
It's slow.
That's right. The vagus nerve is sitting right there by the
It's so
carotid
slow.
bodies.
right.
So if it does go to the medulla, I'm missing that piece.
I'm pretty sure that was
Correctamy.
in Dr. Fowler's.
Yeah, it was in
lecture
Dr.
last
Fowler's
week.
lecture last week.
Was she talking about baroreceptors?
Yes, and it goes to the, through the vagus nerve, goes to the medulla releases.
It like decreases sympathetic outflow.
Right, decreases the sympathetic outflow, and so.
Okay. Well, I don't wanna correct her, and it's been like 6 years since I've really read this. So, you know, sometimes your brain starts, your medulla starts messing up. But the way I remember it, and if somebody can find some reading that tells me I'm wrong, please send it to me. The way I remember it, the vagus nerve is running right by that carotid body. The vagus nerve runs to the SA node. And what I do know for a fact is that the baroreceptors are a parasympathomimetic and parasympatholytic agent. They are not a sympathetic, it is not a sympathetic agent at all. And one of my big proofs there is the vagus nerve. The vagus nerve is all parasympathetic. And that's where it is. When you do a carotid massage, you're not massaging the carotid, you're massaging the vagus nerve, right? And that's actually worked with me. Not on me, but on the patient. But anyways, the student was wild that day, and I didn't even think it'd work. I just tried, and it worked. And they're like, "Oh my gosh, you were so good." And I'm like, "Just lucky." But anyways, so that vagus nerve. So when you have, backing up, you have an elevated blood pressure. What do we know the baroreceptors will then cause for heart rate?
Reduction.
A decrease in heart rate. It does that via parasympathomimesis. So when we say the baroreceptors kicked in the sympathetic nervous system in the presence of hypotension, that's inaccurate. What actually happens is you get parasympatholysis in the presence of hypotension. It's like the parasympathetic nervous system backs off. You got it?
I do.
All right.
It's on your cdphysiology.com.
Let's see what it says.
Okay, the carotid sinus baroreceptors are innervated by the sinus nerve of Herring, which is a branch off the glossopharyngeal nerve. The glossopharyngeal nerve synapses in the nucleus tractus solitarius, NTS, located in the medulla of the brainstem. The aortic arch baroreceptors are innervated by the aortic nerve, which then combines with the vagus nerve, traveling to the NTS, which is in the
medulla.
In the medulla. The NTS modulates the activity of the sympathetic and parasympathetic vagal neurons in the medulla, which then in turn regulate the autonomic control of the heartbeat levels.
It's funny it says the sympathetic and parasympathetic.
So what I understand is
medulla,
that
then
the stretch, the receptor in the carotid senses the hypertension or hypotension, and then send in the glossopharyngeal is the afferent nerve, and sending the information to the medulla, and the medulla might, suppress or increase the tone of parasympathetic and send out the vagus nerve to the effector side. Is that
School.
Is that what I understand correct?
Not in school. Except by anesthesiology. Other than that, I'm all good with being in school. I do stand by the parasympathetic nervous system. But thank you. Good. All right. So it doesn't go correct. Very nice. I still don't get, though, the vagus nerve is right by the carotid. How is the vagus nerve not part of that? Okay, I want to read on this somewhere. All right, moving on. Nicardipine. All right, so of the dihydropyridines, the one that you are going to use the most is nicardipine. Now, the ones your patients use the most is typically like amlodipine, which I think is Norvasc. There's another one that your patients will be on. That's escaping right now. But when it comes to what you do, you'll use nicardipine. There is another drug out there. I have a slide on it called clevidipine. It came out after nicardipine, and I actually was a neighbor with a rep for the company that made it, and I told him, I've got a big problem. And clevidipine is in a lipid emulsion. It looks just like propofol. And I said, you're going to have to, first of all, I strongly recommend if you want if you want anesthesia to use it, you need to well-label the syringe that it comes in, because somebody's going to screw up. What are they going to do? They're going to give somebody clevidipine when they mean to give propofol. What's going to happen? The blood pressure is going to drop. Well, that makes sense. They're going to pass out. Well, that makes sense. My propofol's working great, but it's not propofol. I think that was a reason why it didn't take so much. And also, clevidipine was super fast on and off, too fast on and off. So like, we like things that come and go, but we want it to stick around at least a little bit. And then all of a sudden the blood pressure's high and we give a drug and then a minute later it's high again. I've gotta give some more. So clomidogrel's only used as an infusion. Well, I gotta go get that. I gotta set that up. Forget it, So nicardipine is the king when it comes to dihydropyridines in the OR. That fast onset, fast offset. I can tell you on a practical level, when I give it, within a minute, I have some effect. I probably have bought myself 5 to 15 minutes of effect. That's kind of the way I see it. That's what I see in a practical sense. And then of course it can be used as an infusion. Most places, most worlds of healthcare use it as an infusion. We're kind of the exception. We use it as both because we're treating quick and then moving on. We use it both ways. The package insert describes continuous infusion only. That's an old slide. Maybe they now got it approved for boluses, but we definitely use it in bolus technique. So it's usually made one of two ways. It comes in a 10 milligram, 25 milligram vial. Yes, 25 milligram vial. It's yellow colored, kind of like the liquid is actually a little yellow colored. How many people use nicardipine? So if you get it in a infusion already, you can kind of see that yellow tint. In the vial, it's very yellow. Okay. I mean, like in the wine world, we call that more than straw. Sorry. It's quite yellow. Not quite like urine yellow, but maybe like semi-diuresis yellow. And you will want to dilute it. It's too potent in the way it comes in that vial. So most of us dilute it in a 100 cc bag. That makes it 250 mics per ml. You might want to write this down. I don't know that it's a test question. It's just good to know. Okay. Because when all of a sudden I say go get nicardipine, I want you to have nicardipine ready. It's nice to kind of know how to mix it and how to anticipate using it. Okay. So usually we dilute it in a 100 cc bag. Some people use a 250 cc bag. So if you do a 100 cc bag, it's 250 mics per ml. If you use the 250 cc bag, it's 100 mics per ml.
It's a 25 milligram.
It's a 25 milligram vial. And it comes in 10 cc, so we usually draw that up and just add it to it, so it's a little off of what we claim it is, because it's 110 cc, And so we do everything to effect anyways. Dosing wise, you're typically looking at giving an initial attempt between 125 and 250 mics. So a half to full cc is typically what you're going to use. It depends on the patient, how hypertensive they are, how worried you are about the hypertension, is how aggressive you are on that first dose. But because there's individual variability, I tend to try to go with 125 mics unless I'm really, really desperate to keep that blood pressure down. Okay. And then, there have been some patients where I give more than a cc at a time after that because I've discovered that they're a little more resistant to its effects or they're just that hypertensive. It's given as an infusion, 5 milligrams an hour, moving on up. I have done like a 2.5 milligrams an hour, but typically you start at 5 and move up. And I every now and then use it as an infusion. Probably the only time I typically use it as an infusion is for cerebral, some kind of cerebral hemorrhage / cerebral increased ICP patient who I am now emerging, and I anticipate to be hypertensive at the end of the case. So I'll go ahead and start them on nicardipine drip. Most of the time in actual practice, in the middle of the case, it's all boluses, unless they are just persistently hypertensive. But the thing is, we have other ways to get blood pressure down during the case, that are easily just increase the agent, increase the propofol, all those kinds of things. So there are other ways we treat hypertension in the case. And the other thing is when you're doing anesthesia on someone who has elevated ICP, they tend to be very labile. So we tend to not do the drip thing because we're going to be turning on. So, but when you're emerging them, either to extubate or to not extubate, but they're going to get less anesthesia, that's for sure. And they're hypertensive already, that's time to bust this drip out and say, because they're going to be high, and they don't need to be high. That's not good. So, anyways, So, yeah, 125 to 250. So, very commonly used in neuro cases. Also, vascular cases is great because vascular cases can have high pressure swings, and they also have deleterious actions of high pressure. If you're doing a AAA and their pressure is really high at the wrong time, that's not good. So nicardipine is great for those vascular cases as well. Those are probably the two common places I use them. Another exception might be like, well, that would be vascular. I was going to say like a carotid endarterectomy or something like that. So now you're going to use nicardipine for an elevated SVR. Plain and simple. That's the reason. That's what's going on. Why have an elevated SVR? There could be many reasons. Generally speaking, if their SVR is high, and the baroreceptors have a lot to do with this, if the SVR is high, the heart rate is going to be low. In the absence of any other reasons, like, okay, if they're stimulated, they're hurting, or whatever, of course their heart rate might be high. But if everything else is normal, their heart rate is generally going to be low in a high SVR state. So, you give nicardipine to that patient. The SVR drops. The baroreceptors go, ha! It's not so high anymore. What's going to happen to the heart rate? Reflex tachycardia, or at least a reflex increase in the heart rate. Is that unique to dihydropyridine calcium channel blockers? Are those the only drugs that can cause a reflex tachycardia by dropping blood pressure?
No.
No! What other drugs can do that?
Isn't it hydrolysine?
Hydralazine? Clonidine, although clonidine also, yeah, that's a good example actually, I like that. Same class, but yes. Nitrile?
Mm-hmm.
Nitroprusside.
Every time I say this, it's at least everything I can think of. Pretty much any drug that only works on the vasculature, only works on vascular smooth muscle, peripheral vasodilators, dihydropyridine calcium channel blockers. If they only work on vascular smooth muscle by causing dilation, they will have some degree of reflex increase in heart rate. So if your heart rate's low and your blood pressure's high, and you're thinking of how to treat it, think about the cause, keep that in the piece of it, but you're going to go to something that dilates, that's a peripheral vasodilator, or a dihydropyridine calcium channel blocker. That's where your mind needs to go. Not a beta blocker. Okay? I can think of other drugs, actually, that can cause a reflex tachycardia. You had the lecture. Somebody said hydrolysine. What's phentolamine? What's carboxybenzone? I think that's what it's called. Yohimbine?
Alpha 1 and alpha 2.
Alpha, more specifically, alpha 1 is where I'm thinking. But because alpha 2 antagonist, alpha 2 is a tricky thing. Alpha 2 is way tricky. Why? What makes alpha 2 so tricky? Presynaptic. Typically, now there are postsynaptic alpha 2 receptors, which just complicates everything. But generally, alpha 2 are presynaptic. So alpha 2 stimulation actually causes what to vasculature? Dilation, right? So typically, all right. So, but there's all sorts of. But phentolamine is an alpha 1 antagonist. So if you block alpha 1 receptors, you cause vasodilation, and you will have an increase in heart rate. But if you give them labetalol, what is labetalol? Alpha and non-selective beta, right? Alpha 1 and non-selective beta. So you're going to cause vasodilation with the alpha 1 blockade, but you're actually also going to cause a decrease in heart rate because of the beta 1 blockade. So, so that's the difference, right? So, but anything that only focuses on vascular smooth muscle dilation, heart rate's going to go up or at least stay the same. That's that reflex thing. So your drugs to go to when the heart rate is high as well, beta blockers and non-dihydropyridine calcium channel blockers. Or I mean, there's other things, adenosine, stuff like that. What does adenosine work on? Passage. So, cautions to verapamil, patients taking beta blockers. So I had this anesthesiologist at UF Health years ago, she's not there anymore, very, very smart. But she definitely did not get this one. Because I would have a patient who we had just given some Esmolol to, now their heart rate's a little lower, trying to go another route, and I said, let me give some cardigan. No, you should never give a beta blocker with a calcium channel blocker. Because you might cause them to have AV block. Really? So nicardipine is going to lead to AV block. Is that true? Heck no. So as a matter of fact, sometimes managing patients like F&P type work, you're going to give them a beta blocker and a dihydropyridine because then you can cause that vasodilation but also kind of negate one from the other. Kind of like the heart rate stays the same, you know? So you're going to give them the beta blocker, but if they have too low heart rate, you can add some calcium channel blocker, dihydropyridine, to negate that. Or maybe the other way around is when you give them Norvasc, their heart rate's too high, so add a little beta blocker. So yeah, there's no contraindication whatsoever to mix a dihydropyridine to a beta blocker. Where you have to be careful is non-dihydropyridine with a beta blocker. So diltiazem plus metoprolol, that's where you get tricky. You are watching your patient every beat. You never need to think, well, I just gave the patient metoprolol. I absolutely cannot give them diltiazem. Not true. Okay? Good. But you wouldn't want to send a patient on Toprol XL and Cardizem XR without really seeing what their effects are on them and then go home. Difference, right? So you don't need to treat it as a contraindication, you need to treat it as a precaution when it comes to the non-dihydropyridine and a beta blocker together. Okay.